Good afternoon, everyone. iTech India welcomes all the participants for today's special NDLS session. Today's topic is comprehensive guidance on viral load testing in PLHIV under NACP. Please place all your questions in the chat box. Questions will be taken up at the end of the session. We have Dr. Bhawani Singh sir couldn't join us today. We have with us Dr. Purnima Parmar ma'am, consultant CST division NACO, and Dr. Reshu Agarwal ma'am, technical lead HIV, hepatitis and STI care and treatment WHO. We welcome you ma'am for today's session and request you to start the session.
Thank you so much, Dr. Shweta. Dr. Purnima, do you want to say something in the beginning?
Yeah,
or should I
thank you,
start?
Dr.
Yeah, please.
Yeah, I
please.
would just thank you so much. A very good afternoon to everyone. So, as you all are aware, that viral load testing is a very critical, important indicator for PLHIV clinical monitoring and also understanding the need for switch and substitution of the patient. And why we are having this session and why the revised guidance was shared with the state was there were many queries related to the viral load testing for the LFUs who have reported back to the ERT center, or PLHIVs who are not adherent, who have the ART adherence less than 95%. So what should be the frequency of testing for such patients? So that is why NACO has revised the guidance for viral load testing and issued a letter in May itself. And Dr. Reshu is there with us today to take us through this important session. And I request you all to please ask questions. This is a very good opportunity where you can ask as many questions and whatever doubts you may have with respect to the monitoring of patients related to viral load testing. So thank you so much. Over to you, Dr. Reshu, please.
Thank you so much, Dr. Purnima, for setting up the context. So as Dr. Purnima has already told, that NACO actually released this guidance, which all of you would have received by now. So this was based, this is a comprehensive guidance on what is the schedule for viral load testing, and especially in some of the special groups or special situations, how do you tackle and when do you do the viral load testing? And then this was the revised algorithm which was shared with the OM, which was issued by NACO. So I hope you all have received it. Can somebody confirm on the chat? Have you all seen the guidance? Yeah, great. So for today's session, I want this session to be very interactive and not like one way, so that whatever doubts, questions you have, we should be able to tease them out. So we have this first poll for you.
Yeah, give me a second, ma'am. Kiran sir, can we have the poll, please?
And I would just want to understand that, were you able to understand this guidance node and algorithm, which we really very diligently, it was prepared by the NACO team? Or if you have any issues with it? Please give your honest answer so that I can actually plan my session accordingly.
Oh, please answer the first question. Only the first question, please.
You can be very honest in answering. If you didn't understand, you find it complicated or confusing, that's why we are having this session. So whatever was your perception at seeing this guidance, please let us know. Please be quick in answering because I have so many poll questions today. So I have all these questions in between to understand whether you people are like attending the entire session and really paying attention or not. So I want full attendance in answering these questions, please. We just have 60 responses as of now. Okay, Shweta, I think we can close this poll, huh?
Yes, ma'am.
Thank you for sharing your feedback, and this helps me to understand, like, at what level we are. Thank you so much. So there's another poll which says, as per my understanding, the main purpose of VL testing is.
Ma'am, we'll have to take these second poll questions in the chat box. Answers.
Okay, no problem. Could you answer in the chat A, B, C, D, or E? Just write the option which you think is the correct option. Right. Thanks everyone for providing answers for this, and good that you're answering B or E. That is correct. That the main purpose of doing the viral load testing is to understand the response for the treatment, and the rest of the things are the secondary purpose for viral load testing. And under the national program, all PLHIV who are on ART, if they have HIV-1 or if they are co-infected with HIV-1 as well as HIV-2, and they have been on ART for 6 months, they all are eligible for the viral load testing. And for the patients who just have exclusive HIV-2 infection, they need to be monitored by CD4 counts and not through viral load testing. So does everyone know what is the frequency of viral load testing among PLHIV for first line on ART? On PLHIV on first line ART? You can answer in chat. So excellent. I think everyone knows that for the PLHIV who are on first line ART, the viral load testing has to be done at 6 months, then at 12 months after initiation of ART, and thereafter annually. Now, what is the scheduled frequency for viral load testing in PLHIV on second line or third line? Yes, right. So it has to be done every 6 months in PLHIV who are on second line or a third line ART. So do you all know that a viral load test is required among pregnant women around 32 to 36 weeks of pregnancy? Could you identify the reason for this? So I think I'm getting a mixed kind of thing, but most of you have answered it correctly. So the correct answer is to decide the appropriate infant prophylaxis. So if there is a pregnant woman, it does not matter that for how long this pregnant woman has been on ART or what was her previous schedule for viral load testing. All pregnant women, irrespective of the duration of ART or previous schedule, need to undergo a viral load test between 32 to 36 weeks of pregnancy, that is before the delivery, so that appropriate prophylaxis for the baby can be decided whether they need a single prophylaxis or a dual prophylaxis. Now, coming to the clinical interpretations for viral load testing. So as we were saying that we want to monitor the response to ART through the viral load test. So what are the results you get in your viral load test reports? One is, I'm starting from the bottom. So the first one is the patient has an undetectable viral load, or what is called the TND, target not detected. And this means that the virus is not detectable and ART is really working very well in this patient. So the response to treatment is good. There is no measurable virus. And this condition is also called U equal to U, which means that there is a zero risk of transmission to sexual partner or a very minimal risk of transmission from mother to child. And this message of U equal to U is really a very celebratory message, and which you can actually use in your counseling to motivate the patients that once you become undetectable, then you really don't transmit virus to your partner. Or for counseling of the pregnant baby, pregnant mother, that if you are like consistently on ART and virally suppressed and your virus is undetectable, then the chances of transmitting virus to the baby are very, very minimal. But whenever you get these kind of results, it's very important to emphasize to the patient or PLHIV that it does not mean that HIV has disappeared, because HIV always remains in the reservoirs, and therefore it is very important to continue the ART regimen. ART has to be taken and a follow-up viral load has to be done as per schedule, and so that we know that patient is consistently or is sustaining the viral load, undetectable load. Then coming to the next level, which is viral load less than 1,000. So this means that patient is still suppressed. ART is working here, and you need to continue with the same ART. But obviously here also you want to give a message to the patient that there might be still some adherence issues, that he or she should be taking the ART more regularly. But you need to continue the ART and appreciate the patient here. And the third piece, which is highlighted in red, is the viral load more than 1,000 copies per ml. So this means that virus is not suppressed. Now, when the virus is not suppressed, there are two conditions which may prevail. One is ART may be working, but the patient is not taking it properly. The other would be the ART may not be working due to resistance or treatment failure. And we really need to look into both the issues. And in the subsequent slides, we will discuss how do you really manage these patients who have an unsuppressed or a not suppressed viral load, which means the viral load is more than 1,000 copies per ml.
Excuse me, ma'am. We can launch the e-poll now for this question. Praveen
Okay.
sir, can we have the
Yes,
question
please.
6, please?
Yeah, sure.
So the question is for a PLHIV who is on ART for more than 6 months, but the adherence is less than 95%. When should the routine viral load test be done? Do you wait till the adherence improves to 95%, or you do it as per schedule? right? So nearly 40% of the participants are saying that we should wait till the adherence improves to 95%. And rest are saying, almost 60%, that we do it as per schedule. So in this condition, when the patient is not having a good adherence, this scheduled viral load has to be done as per the timing or the frequency which has been pre-decided. So adherence does not matter here. The only thing is what you need to take into consideration is that this patient should be on ART for more than 6 months, and the viral load should be done as per schedule, irrespective of the adherence. Why? Because I think most of you think that because the patient is non-adherent, you already know that the patient is non-adherent, he or she is going to be virally non-suppressed. But then when you have a patient who is virally non-suppressed, what do you do for such patients? Quick answers in chat. If you have a patient who is virally unsuppressed, what do you do for such patients? Yes, you do EAC for such patient. So obviously this patient who is not adherent to treatment, we really want to be more focused with this patient, give a more prioritized attention to this patient and support this patient in improving the adherence. So we want this patient to be put on EAC if the adherence is not improving. So that's why the scheduled viral load has to be done irrespective of the adherence. Adherence does not matter. So for the patients who are on first line, viral load has to be done at 6 months, 12 months, and then annually thereafter. And for the patients who are on second line, on third line, it has to be done every 6 months. And in case you find that the patient is having an unsuppressed viral load, then these patients should be put on enhanced adherence counseling or step-up counseling. The other reason for this is because the viral load indicator is also a program monitoring indicator. So you all know about the 95, 95, 95 target. So the third 95 actually stands for proportion of patients who are virally suppressed. So because in case you don't actually measure viral load in patients who are non-adherent and perhaps they will be unsuppressed, we do not report the actual viral load suppression level. So we never know what is the population viral load suppression level in our patients. So it's very important both from the patient's perspective as well as from program's perspective to do the scheduled viral load amongst all the patients irrespective of the adherence. Also, I think an important observation which has been found is that a lot of patients have never undergone a viral load test because their adherence was never good. And usually because I think that because the guidance was not very clear in the earlier versions of the guidelines. So usually the ART centers were not doing the viral load test among these patients. So now for any PLHIV who has completed 6 months and has not undergone any viral load test, they should be prioritized for viral load testing irrespective of adherence. If they are virally suppressed, well and good, you still counsel them to improve their adherence. If they are not suppressed, in that case, they should be put on enhanced adherence counseling or step-up counseling, right? So till now, what we discussed was about the timings of the scheduled viral load. So for the first line, it is 6 months of ART, 12 months of ART, then annually. For the second line patients, every 6 months, it has to be done. The scheduled viral loads needs to be done irrespective of the adherence, and the patients who have never been tested for viral load test should be subjected to a viral load test. And for the pregnant women, the viral load test should be done between 32 to 36 weeks of pregnancy. So these are the timings for all groups of patients. Now, this is the guidance or the algorithm which you had for viral load testing as per the 2021 guidelines, and this was discussed in your last training modules also. So everyone remember this guidance? Yeah. But I think what we were getting was very frequently asked questions that for how long EAC sessions need to be continued if patient remains, if the adherence of the patient continues to remain less than 95%, and when should the repeat viral load test be done, when such patient should be referred to CESIP. So because there was these ambiguity, or like, no, the guidelines were not very definitive, like what is to be done in such cases, and that's why a revised algorithm was issued by NACO. So before we get into the revised algorithm, can I ask you to answer for this poll? Poll 7.
Praveen sir, can we have the question 7 poll? Thank you. Participants are requested to kindly attempt the poll. Requesting participants to please attempt the poll. Even if you're putting messages in the chat box, please attempt the poll also.
So 2/3 of you are saying that it's first line, and 1/3 of the participants are saying it's second line or third line. I think currently, because the regimen which we are using in the first line is basically single pill of TLD. So it's a FDC. It is just one pill. It has very least side effects. It's very well tolerated. So the chances of having a good adherence among PLHIV on first line would be comparatively high than somebody who is put on second line. Because for the person who would fail on TLD, the second line would be a PI-based second line, mostly with ZL. So it would be ZL-ATVR. And then what you have with ZL-ATVR is a higher pill burden, more side effects, less tolerance, and that's where somebody who the chances of somebody adhering to the second line treatment really decreases. And that's why I think the entire premise of the national program is to prolong the patients on first line as far as possible. And most of our patients in the program are on first line, especially when we are talking about the DTG-based regimen. So since the introduction of the DTG-based regimen, the failure rates or the unsuppression rates have really gone down. So most of the patients are really responding very well to first line ART, which is TLD. And we really want to prolong their first line regimen and not to put them on a second line or third line where, especially the second line, where they would be deprived of a DTG-based regimen and the pill burden or the complications or the adverse effects would be comparatively high. So as I said that this part in the previous guideline was not comparatively very well defined, that if somebody who is having an adherence of less than 95%, even after step-up counseling, what needs to be done? And that's why NACO came up with a revised guideline, which was shared with you in your OM. So what you see here is in different colors, but I just tried to simplify this for you people. So the overall algorithm remains the same. You subject or you ask a person to undergo a viral load test. If the viral load is less than 1,000 copies per ml, then you continue the same regimen. If the viral load is more than 1,000 copies per ml, then the PLHIV has to be initiated on EAC or the step-up counseling. So there is no change till now. After step-up counseling for 3 months, if the adherence is more than 95%, then you conduct a viral load test, which is on the right side. So right now what I have is basically on the right side of the algorithm. So basically you do a repeat viral load test And if the repeat viral load test is less than 1,000, you continue the same regimen. But if the viral load is more than 1,000 copies, you do a referral to SACEP. So this piece remains the same, whatever you had in the previous guidelines. Now on the left side, which is like given in the red box. So if you have PLHIV whose adherence has not improved after your 3 months of EAC, what do you do? In such cases, a repeat round of EAC has to be done by a different counselor under the supervision of Emma. And then after this second round of EAC is completed, then you do a viral load test. And now if the person is suppressed, you continue on the same regimen. If it is not suppressed, then the person has to be referred to SACEP. Now here the purpose of referring the person to SACEP is not the switch to the next line of regimen, but we want a more detailed evaluation of this patient, especially on the adherence issue by the SACEP. So please keep in mind, especially the ART plus centers, the COEs who are here. So now, as per this algorithm, there is an added responsibility for all the SACEPs, that if you are getting a person who is unsuppressed after EAC, you need to be quite more vigilant in such cases, do an in-depth review of these patients, look out for the adherence issues and support them with the adherence, and instruct your ART center what else can be done in such patients to improvise on the adherence. So, but you don't want an unnecessary or an unwanted switch. So we'll discuss this algorithm in more details in the subsequent slides. So I just wanted to clarify what does this additionality, the red piece which I showed you in the last slide in the algorithm, what does this aim for? So obviously this aims for to give you better defined processes for the management of PLHIV who have unsuppressed viral load. At the same time, we really want to improve the quality of the EAC. Because what has been seen is at times, especially for the failing patients, when you do the first round of the step-up counseling or EAC, it is just telling the patient that, okay, please be adherent to the treatment and actually not being solution-oriented. So the EAC needs to be very effective. It needs to be solution-oriented from the day one. So whenever you have an unsuppressed PLHIV, you need to identify the barriers and provide solutions for that, and not just counseling or EAC just for the sake of the word and just buying another 3 months. We obviously don't want that the adherence issues should be lingering. So whatever best can be done in terms of improving the adherence of these patients should be done. Whatever support you can give to these patients, if they need an adherence plan, if they need maybe more frequent reminders, if they don't understand for how long they have to take the medicine or how they have to take the medicine, or if they are I'll discuss in subsequent slides if they have financial issues or travel issues in coming to the ART centers. So everything has to be considered, and whatever possible solutions you have, those solutions need to be provided. And this has to be done from the very beginning of day one. You don't have to wait for EAC to, or keep waiting for your best thing. So whatever best you have, whoever is the best counselor in your ART center, whatever best solutions you can give, you should start giving those solutions at that counseling from day one when you start the EAC in such patients. So obviously, we want a very fine balance so that unnecessary switches should be avoided. The adherence should be maintained for such patients. But at the same time, we also don't want that the PLHIV should be continuing on a failing regimen unnecessarily. So there has to be a very fine balance, and that's why this additional piece was added into the algorithm. And a very critical element of this additional piece is that we want the SMO or MO to be involved in the EAC or in the care of the PLHIV who have an unsuppressed viral load. So I think I would want to share that with the introduction of DTG-based regimen, the proportion of patients who will have an unsuppressed viral load in ART center would be very minimal. If you are a good performing ART center, it would be to the range of 2%, 1.5% or 2.5%. If there are some issues, and so it could range like maybe higher, but on an average you will get like 4 or 5% patients only. So these 4 or 5% patients who are unsuppressed as per the first viral load, that group of patients is not a very big group. That number is not very big. It is very much manageable, and that's why SMO or MO at the ART centers should be engaged in the EAC from the very beginning. So this is a very clear message from this new guidance. So what does this additionality in the viral load algorithm not mean? What does it not indicate? So it does not want any unnecessary or injudicious switch. So as I said, that obviously when we are asking you to send the patient to SACP, the only job of SACP is not to just look into the next line of regimen, okay, and prescribe it. No. There has to be an in-depth review of the adherence and clinical issues. There might be some clinical conditions which might be adherence with the viral load suppression. There might be some adherence issues which may have been missed by the ART center. So we obviously want a different set of providers to look into this issue and really provide a better care pathway to the patients, and not just an immediate or an unnecessary switch. So this piece is very important. And please, all of you, I want all of you to take note of this pink highlighted piece, that all the PLHIV who are unsuppressed will not be benefited by switch in the ART regimen, because most of these patients are unsuppressed because of the adherence issues. And if the adherence improves, they would definitely respond better to the existing ART regimen, for sure. So in the same line, I just wanted to share this data from the recent WHO drug resistance report. And they did the systematic analysis of all the clinical trials which are published as of now. And what they found, that the drug resistance among PLHIV who are unsuppressed on DTG-based ART is very low. And therefore, like in the title, you will see the heading of this slide is actually viral load non-suppression is not equal to failure on ART. Viral load non-suppression could be due to adherence issues as well, and it does not indicate ART failure, especially among our patients, because for us, most of the patients are on DTG-based regimen now, and it's only just 2 years or 2.5 years only for DTG introduction of the DTG-based regimen. So at least as of now, we should not be seeing a very high unsuppression rate or a failure rate. The same report actually said that for the treatment experienced patient, the PLHIV who were already on ART and who were unsuppressed before transition to DTG-based regimen, in those, the actual drug resistance level or the failure level was only 1.6%. And for the PLHIV who were ART naive, who were newly initiated on ART, or who were already on ART at the time of transition but had a viral suppressed viral load, for those patients, the treatment failure rate or the resistance rate was only to the tune of 0.1%. So if you have in your ART center, if you have say 100 patients, so obviously of those 100 patients, only 1.6% of the patients, if they were not suppressed before DTG initiation, could be failing, and only less than 0.1% patients, if they were newly initiated on ART, or if they were suppressed before transition to DTG-based regimen, they could be failing. So this gives you an insight that why the EAC or doing a quality enhanced adherence counseling is very, very important. And it's very critical for the ART centers to look into the critical care indicators at your ART center, especially when PLHIV are coming to you. Are they picking up their drugs on time? Because at times patients, they say till the time they have the drugs, they take it very regularly, but then they don't come for pickup on time. And that happens very habitually. Every time, every alternate month, they will not be coming on time. Retention on ART, obviously, you should have the lowest possible missed and LFU rates. Your viral load testing coverage should be good. And as we said, for all patients, viral load testing should be done irrespective of the adherence level. Timely viral load testing should be done, especially for second especially for the second viral load test if after the EAC and your viral load suppression. These are some of the key indicators which are very critical, and these indicators are actually part of your scorecard. So if you really have a scorecard in your ART center, and I know most of you are generating your scorecard, so if you have your scorecard and really monitoring these indicators, you should not have a lot of patients who are unsuppressed on DTG-based regimens. So as I said, that all unsuppression or all non-suppressed patients don't mean that they are failing. And usually, the reasons which we are seeing in most of the centers for the unsuppressed viral load is obviously the overall poor adherence because of the barriers in adherence. There are some intrinsic adherence issues there, and these patients may not be taking ART as prescribed. They might not be picking up their pills on time, or they might be becoming missed or LFU. The other thing which was noted was the suboptimal or partial, sorry for this typo error, or the partial adherence. So if the patients are not on FDCs, especially if they are on multiple ARVs, which needs to be taken at a different time, usually they take one drug, or maybe they will take the morning pill and not take an evening pill, and they think that they are adherent, but they are actually being partially adherent. And whenever we talk about adherence monitoring, we say that for each of the ARV drug, if they are not available in FTC, you need to do a adherence verification from the patient. So this is very critical, and it has been noted, because I think the data which we analyzed for NACO, what we saw that the patients who are on, say, basically ZL DTG or on other regimens except for TLD, they were having a high non-suppression rate, because ZL has to be taken twice a day, DTG is a separate drug, so they might be missing on some of the things. So, but then you can go back and look into the data of your ART center, on what drugs your patients are non-suppressed, and perhaps you might find a similar finding that the patients who are not on a OD dose of FDC, the unsuppression rates or the non-suppression rates are comparatively high. The third thing which you need to keep in mind is the suboptimal absorption or the bioavailability of the ART. And especially the patients who are taking some of the supplements, multivitamins or antacids, which have the cations for aluminum, calcium, iron, magnesium, or zinc. So they might not be maintaining a good interval of 2 hours, which is indicated. And usually, because this is the human tendency to take all the pills together. So this is also one of the reasons which has been found when we interact with the patients, that they were taking the entire bunch of pills together. So please do look into the drugs which the patient is taking, any concomitant medication if the patient is taken. Secondly, if the patient is on anti-TB treatment, at that time, 50 milligram extra dose of DTG has to be given. And it has been seen that patients, because they have to take ART, they have to take ATT, and then this additional dose of DTG. So at times they might be missing on this additional dose. So these are the possible reasons of being unsuppressed, and especially because obviously we don't expect a failure in these patients. So perhaps fully overall poor adherence, suboptimal or a partial adherence, or they might be taking the drugs properly, but then they might be taking it with some other drugs which might be interfering with the absorption or bioavailability. So these are the reasons which have been found. And please, I'll urge the medical officers here to please look into all these issues whenever the EAC is being done. So as I was discussing, this is the data from the program, and is from one of the state. So here what you see is basically this state has had nearly 15,000 PLHIV who had a viral load more than 1,000 copies. And of them, because this state was maintaining a good EAC cascade, so of them, 95% actually underwent EAC. Who were initiated on EAC, of them 94% completed the EAC, and for 80% of the PLHIV, repeat viral load test was done. Now for the PLHIV for whom the repeat viral load test was done, of them 85% of the patients became suppressed after EAC. So which is really very reassuring that if you really do and this was in the program mode and before the guidance which NACO issued was actually released. So before that, even with the regular mechanisms, you see that with a good step-up counseling, even if you do in a routine programmatic modality, without any extra effort, 85% of your patients would be suppressed. And 15% of the patients were still non-suppressed. And obviously of them, basically 29% were referred to SACEP. And then actually SACEP recommended the second line regimen only for the 23% of the patient, which is 102 patients. And for 38% of the patient, they said no, same regimen has to be continued. And then for 12% of the patients, they said that they need a referral to a COE. So I just wanted to show you this cascade, not to get into the numbers, but to get into the process. And this is something I would expect, or NACO would expect, from all ART centers, that you should have these kind of data for your ART center. This graph should be available for each of the ART centers, and you should be monitoring it. And obviously, the graph which I'm showing, obviously there are some gaps, but at least something is being monitored, it is being done. And if you really do a good EAC, most of your patients would become suppressed, and a very minimal patients would be requiring a change in a regimen. And what you see is you started with 15,000 patients and only 102 patients of this, which is I think less than 0.1% actually were transitioned. I mean, there's gap in some referrals, but then even then, if you see the overall requirement for your switch will not be no more than 1% amongst the patients who are unsuppressed initially. So this graph strongly shows that EAC is very critical. And if you really improvise on the quality of EAC, obviously this 85% suppression after EAC might even become 95%. The other piece, what we have seen is the on-time pill pickup, which is very critical. And the program actually analyzed the data for nearly 7,700 patients who had an unsuppressed viral load. And then in these patients, we saw that whether these patients were picking up their drugs on time or not on time. So of these, around 8,000 patients, 15% patients were picking up their drugs on time, but 85% of the patients were not picking up the drugs on time, and at least they were picked up late. At least they missed their pill pickups at least more than 3 times in last 6 months. So you see here that if your patients are not picking up the drugs regularly, so it's very important. In the white card, you always have this due date and when the patient's visit date. So please compare that due date and the patient visit date. And if the patient is coming late, obviously every time he will be missing some doses, and this is a typical risk for actually developing the resistance. And we really want to prevent resistance. We really want to prevent failure. And so this kind of phenomena of patients being regularly irregular is very critical to monitor. Please see into the pickup dates and the due dates, and please cross check them. And if the patient is coming late, from the very beginning, start counseling these patients. Don't even wait for the viral load test. But if they are scheduled for viral load test, obviously you do it. But then this is something which is very important for prevention of having unsuppressed viral load. So I think I'll take a pause here. Are there any concerns, any questions till now? Or should I continue? So I'm reading Dr. Neetu's question that will be addressed in the subsequent slide.
Ma'am, is it okay to take the questions at the end?
Okay, sure.
Yeah. And also, ma'am, we have few participants watching this session on the YouTube channel as well. So requesting those participants, if they have any questions, they can put them on the YouTube channel also. We'll take up questions from there also.
Definitely.
Thank you, ma'am.
That's excellent. So moving forward, I think these are the detailed SOPs which are prescribed for the management of PLHIV with the unsuppressed viral load. So first is the EAC1. What is expected is like, whenever a viral load test report is available, a line list of all the PLHIV who have an unsuppressed viral load or viral load more than 1,000 copies per mil needs to be prepared. This list needs to be shared with the counselor, and I am hoping that after the ART capsular trainings, everyone is actually implementing package A, B, and C. So these the list of such patients should be given to the counselor who is managing the package C, and all these patients should be telephonically contacted to come back to the ART center. Obviously, you don't want to wait for another month for such patient because they are not suppressed. And their step up, and then a 3 months step up counseling is to be done for these patients. And this counseling, as I said, should be focused on identifying the barriers and providing solutions. Please do not do EAC or a step up counseling just for the sake of saying and doing a checkbox. Ideally, all the sessions of the EAC should be done by the same counselor so that he or she is aware of of the continuity of what the patient told last time, so that you are really able to follow, and so that the consistency, continuity, and issue resolution is done. And this also helps in rapport building, because maybe during first visit, patient told you a lot of things, but then during the second visit, the patient is meeting another counselor. So obviously, it's very difficult for the patient to repeat the same things and even to get a new set of advice. So it's always advisable that the same counselor should be doing all the sessions of EAC. Based on the patient's profile, you can decide you want to do what should be the frequency of these sessions. These could be 15 days or 1 month, but ideally it is advised that they should be done whenever patient is coming for their pill pickups. There are ready reckoner and EAC form in the operational guidelines, which you all should be referring to. And the other piece, which is very critical, whenever the step-up counseling or EAC is undergoing, please do if the testing for the spouse or partner or the children has not been done, or if they were negative long back, so their retesting should be done in such cases, because obviously the patient is unsuppressed and the chances of transmission would be there. So this also needs to be kept in mind. As I said earlier, obviously the involvement of SMO and MO from the very beginning of the EAC has to be ensured. Your EAC from day one has to be effective and quality EAC, and whatever best you can do for the patient has to be done from the day one, and not wait for the last leg, or let the patient fail as per the for the repeat viral load, and all those things should not happen. You should not postpone your interventions. Try to do the best interventions from day one. And for all the information, whatever barriers you identify, or the patient is taking any concomitant medication, and whatever actions or adherence plan you actually suggested to the patient, that needs to be documented in Annexure 6, which is a EAC form in the operational guidelines. So this is a ready reckoner which is available. I'll not go into detail on this. So this is basically the session 1, and on the left side you see the EAC form which is available, and this is very easy, just a checkbox kind of a form, so you don't have to write a lot of things. You can just tick mark these things, but then it is very important to have that continuity of the discussion, because if you are a high load center, you dealt with some patient, and this patient comes after a month, you will not even remember what did the patient tell you, so or what you told to that patient. So it's very important to document what was discussed, what barriers were identified, what interventions were suggested. And this will help you to understand what is the progress made, when the patient comes next time, what is the progress made from the last time. So for the first visit, as I said, it's very important to do the pill counts and also the on-time pill pickup check, whether the patient was adhering to the appointments and not or not. It is very important whether patient understands ART. Do they really know that the patient ART has to be taken for lifelong on the same time, and it has to be taken as prescribed, and discuss the possible reasons for a high viral load as we discussed in the previous slides. Then it's important to identify the barriers, the knowledge of medication, duration and the timing, motivation to take the medications, any side effects, working timings, stigma which might be interfering with any mental health condition or concomitant medications. Also discuss the patient support system, and it's very important because you would remember, those who have been in the program for a very long time would remember that there is always a concept of caregiver, and caregivers counseling is very important. And in the sessions when we talk about ART initiation, we always say that the counseling of the caregiver is very important. You need to involve caregiver from the very beginning in the patient's treatment. But especially for when you're dealing with the unsuppressed patients, please do identify, if you have not already done, who is the caregiver, what is the patient support system, and involve them in the patient's adherence mechanism. And then check for the patient's history, whether they were adhering to the if they any referrals were made, did they take that or not? So that this will give you some idea, is the patient really having some issues? And then based on whatever barriers, whatever issues you identified with the adherence, you help the patient in developing an adherence plan. And when the word adherence plan sounds very big here, but on the left side, when you see, it's very simple, what are the interventions you have suggested to this patient? That's the only thing you have to do here. Right? So then EAC 2, when the patient, sorry, the session 2 of the EAC, that's month 2 basically. So in this, you again assess for the adherence since the last visit, any new gaps, any issues, whether, and again, please see whether this time patient came on time or not for pill pickup. If the adherence is good, please do appreciate the patient and motivate him again. And see whatever strategies or interventions you asked or you planned, but they really followed or not. Is there any, if the patient is still the adherence is not good, then see do you need to make any modifications in the plan? And then obviously counsel the patient, tell him and ask him to come back after a month. For the third session, again, you review the adherence between second and third session, identify any new issues, support the patient in modifying the adherence plan, right? So this would be done in the third session. And then when the patient comes for the fourth session, you have to decide the next course of action. So if the adherence is more than 95% for 3 consecutive months, you repeat the viral load. If the viral load is less than 1,000 copies, obviously you appreciate the patient and you continue the same regimen, and the next viral load has to be done as per schedule. If the viral load is more than 1,000 copies, in such cases, a e-referral has to be made to SASM. Now, if the adherence is not good, if it is less than 95%, obviously you have to plan for further sessions for EAC. That means your first round of EAC didn't work, and you really need to intensify your effort again. Right? So this is the line list of the patients who have an unsuppressed viral load, and how you are following them up, especially in terms of EAC or step-up counseling. That has to be documented for each patient. And again, all ART centers are requested to please maintain this template for your centers. How many of you are doing it? Good. So those who are doing it, it's really good. Those who are not doing it, please do it. This will help you to follow your patients better and create the graph which I showed you. So when I was talking about the solution-oriented EAC, so issue which is always brought up is on the patients are poorly adherent because of the long distance travel issues or financial issues, or they don't have a caregiver to accompany them, or they have a conflicting timing with the school or the work schedule. So such patients can actually be given some flexibility on a case-to-case basis. They can be linked to a link ART center, and then a rigorous follow-up can be done, especially if you have the LHCs in community-based sites, or if you have other models like car groups. So those kind of things can be considered. So obviously, because these patients are non-adherent, and if you really don't do anything to address the cause, nothing is going to change. So this is something, this flexibility you can exercise. Now, coming to the patients who were non-adherent, even after the first round of EAC. So for such patients, EAC has to be continued for another 3 months, and we call it as EAC2 now. And in this EAC2, obviously, you need to use more enhanced strategies and a greater involvement of the SMO and MO. Obviously, maybe in the first round of EAC, maybe you were not able to identify the proper barriers or address them. So that needs to be done. Even a more rigorous telephonic follow-up can be done, because at times patients tend to forget, or they have issues, they don't take the medication. So a more rigorous telephonic follow-ups can be done. You can even involve the CSC outreach workers to do the home visits. So those kind of modalities can be tried for this patient. And obviously, the number of patients who would still be having a poor adherence despite of EAC1 should be very low. Usually, when you do a good round of EAC1, if you do a good EAC for first 3 months, obviously, most of your patients should become adherent, and then this would be a very small group of patients who are still non-adherent. And please try to understand that if they are still non-adherent, they really have some basic issues, either in their circumstances, in their understanding, which is really interfering with the adherence. And then, once you have done this second round of EAC, after doing this second round of EAC, all PLHIV should be subjected to viral load testing, irrespective of adherence. We want to know what is happening, because at times, what happens, because even when we say 95% adherence, it is ideal to have, but maybe somebody with 93% adherence or 92 might also get suppressed. So we really want to understand how these patients are responding to ART, and we want to do a viral load in these patients. Now, if after this viral load, if they are suppressed, obviously you continue on the same regimen, but the adherence was poor in these patients, and they might become off track anytime. So the more rigorous follow-up for adherence, even if they are suppressed, needs to be done, and a repeat viral load test to be done as per schedule. Now, if these PLHIV are non-suppressed, so you have done a 6 months of EAC, that means EAC1 plus EAC2. Even after that, if they are non-suppressed, we need to refer these PLHIV to SASEP. And then we will discuss what needs to be done, and especially for the same ART centers where the SASEP is done in the same institution. If possible, physical presence of the patients can be ensured. Tele-SASEP can be done, a virtual call can be done with the patient, but there has to be a dialogue with the patient by the SASEP members. So when these patients are sent to, when you have these patients with unsuppressed viral load, obviously you want to send them to SASEP for a more in-depth review and a dialogue with the patient. And what is SASEP expected to do here is SASEP should reassess the adherence and try to identify the barriers, because at times what happens, this decision to refer to the SASEP was taken to have a more neutral, independent review by a new set of providers. At times what happens, maybe patient is really not comfortable with the ART staff in which he or she is going, may not reveal the entire issues. Maybe there might be some stigma. So there could be any issues, or maybe the messages which the ART center was providing were similar messages and did not actually click the patient. So it could be like ART center could have tried their very best, but still it didn't work. So it could be issues related to patient. There could be issues related to the providers, and that's why this decision was taken by TRG that let's have some involvement of the SACEP here, because this gives a third party kind of a view here and intervention here. So SACEP is expected to reassess adherence, look into the barriers with a more focused approach, and at times patients also feel that they have been referred to SACEP, and if somebody is discussing with them on phone or on a virtual call, they might feel that some higher center is actually consulting them, and the messages might be comparatively well received. So that is the purpose. And complete history, if any barriers to the adherence are there, history of personal habits, any addictions should be taken. Look into OI or clinical condition or comorbid condition, which might even interfere with the suppression rates. Mental health issues, especially for depression, which is also one of the reasons for not adhering to the medication, and any concomitant medication. So these things should be looked into. And if the SACEP finds that still there are some issues with the adherence, patient is still non-adherent or has any other concomitant medication which is interfering with the absorption of the drugs, in such cases, the SACEP is expected to do an in-depth and more focused counseling. And also, these patients should be at least weekly follow-up, who are actually put on EAC pack by SACEP. So at least somebody is actually a higher center is actually monitoring what is happening. And we don't expect a very big group of such patients. This number is going to be small. So don't get worried that you will be overwhelmed with the patient. It would be a very small number. But please, all the SACEPs, don't be in a haste to switch the regimen. That's not the only job of SACEP. SACEP should be looking into the overall well-being of the patient and what is good for the patient, and if the current regimen on which the patient is, if that can be prolonged, nothing like it. So we really want to work on that aspect. I think I can skip this. So there's this.
Yeah.
So we are done with the EAC piece, and now we are moving into a different issue. So for PLHIV who are tracked back after being lost to follow-up, when should the viral load test be done?
Praveen sir, can we have the question number 8 e-poll?
Sure.
Thank you to all the participants for placing the answers in the chat box, requesting them to attempt the e-poll as well. Participants who have placed their answers in the chat box, please attempt the e-poll also.
So do you do a test, viral load test whenever the patient is coming back at ART reinitiation time, or whenever the adherence improves to more than 95% after 3 months of ART reinitiation and AC, or as per schedule? Yeah, so I think most of you got this answer correct. And let's discuss this in more detail. So what happens with the patients who are re-engaged in care, or who are who are tracked back and then they are reinitiated on ART? What we see, this is the program data, that almost 1/3 of the patients become LFU again, missed or LFU again. So this is the data we saw, like, when between October and December, like 4,000 patients were started on treatment again. They were tracked back, and of them, like, after 3 months, only 73%, and after 9 months, like, only 65% were retained. So the thing is, like, these patients really have issues in terms of like continuing their ART, and there are some intrinsic barriers which really interfere with their retention on ART, and these patients become LFU again and again. So that is the concern. And that's why, like, what the TRG decided was, for the PLHIV who are being tracked back after becoming LFU, they should be offered EAC. So obviously, we don't want these PLHIV to become LFU again. They have barriers to retention, barriers to adherence, which should be addressed. And that's why all PLHIV who are being tracked back after being MIS or LFU, they should be offered EAC. Viral load should be done after 3 months of EAC, irrespective of the adherence or the previous viral load schedule. Now, if the viral load is suppressed, good, you continue on treatment. But if the viral load is more than 1,000 copies, then EAC needs to be continued for another 3 months. So whatever we discussed, like EAC1 and EAC2, the same concept applies here. So I think with this, I have come to the end of my session. So just to re-emphasize or summarize, so all PLHIV newly initiated on ART, viral load should be done at 6 months, 12 months of ART initiation, and then annually every year. For the PLHIV on second line and third line, viral load test should be done every 6 months. For the positive pregnant women, additional viral load has to be done between 32 to 36 weeks, irrespective of the duration of ART or the previous viral load schedule. And the PLHIV who are tracked back should be offered EAC, and viral load test should be done after 3 months of EAC, irrespective of the adherence level or the previous viral load schedule, and then you follow up accordingly if they're suppressed or non-suppressed. For the PLHIV who have an unsuppressed viral load, they should be subjected to EAC1 or to 3 months of EAC as a first round. And if their adherence is good after 3 months, they undergo a viral load. If their adherence is not more than 95%, then EAC round 2 has to be done. Another EAC for 3 months needs to be done. And from the day of starting EAC1, all efforts should be made to give a quality EAC or an effective EAC to the patient. It should be done by the same counselor. MOs should be supervising. And when you are starting EAC2, then in that cases, you can use a different counselor under the supervision of ART-MO, because obviously something didn't go well between the patient and the first counselor. Maybe because all counselors, they try their best. But then the thing is, at times, like, no, you could, like, no, manage to convince one patient and maybe not another. So that's why, like, no, you want a different counselor when the EAC2 is being done. And after EAC2 is done, then you subject all the patients to a viral load test. If the viral load is suppressed, you continue the same regimen. If not, then a CESEP review should be done, and CESEP should be focusing on the adherence issues rather than just thinking of a switch. So I think I would want to conclude my session with the same question which I asked initially. Now, after the session, do you find the guidance note and updated algorithm simple and clear, easy to comprehend, complicated, or confusing? I know during the first poll, a lot of you did not answer. So, and I assume that they did not understand the guidance note. So can we have a quick poll?
Yeah. Yes. Yes, ma'am. Praveen sir, can we have question number 9? Praveen sir, can we have the e-poll for question number 9? Ma'am, I think there's some technical problem.
No problem. Can you do it in the chat box?
Yeah, we are getting responses in the chat box, ma'am.
Okay, great.
Mostly A and B.
Right. And still, if people still feel that they are at C or D, we will still have an open discussion now. And if you still have any problems, we can discuss more. So we're open for the discussion.
Thank you, ma'am. Thank you so much for facilitating this important session. Ma'am, can I share my screen for the questions?
Yes, please do.
Yeah, is the screen visible?
Yes, it is.
A few questions have already been covered, but if we can reiterate, the first question is, there are some who virally not detected, but CD4 is below 350 or lower. Is U is equal to U applicable here?
Yes, so U equal to U is actually applicable irrespective of the CD4 count. So CD4 counts actually, they indicate the clinical condition of the patient. But since the virus is like no TND, it's not detectable. So obviously the chances of or the risk of transmitting is I mean, with the TND, the risk is not there for the sexual partners and a very minimal risk for mother to child transmission.
Does U is equal to U imply to window period?
Not really, because in the window period, obviously the virus is actually replicating. And we do not do a viral load test. I mean, ideally, we don't recommend a viral load test during this period. And window period is a time when the virus is actually multiplying in the body. So you may not be like picking it up through your regular antibody test, but then the virus is there, and we don't like under the national program, we don't use a test to pick up the virus during window period. So U equal to U does not imply during the window period.
Is second round of EAC also for 3 months?
Yes. So just to
How
simplify
long?
the guidance now, we made it like, at least you do a first round of a good EAC, which we can call it EAC1. And then like, if the patient is still non-adherent, then we do a second round.
How long can EAC1 and EAC2 be extended if adherence is not good?
So the thing is, when adherence is not good, we really need to look into the barriers to the adherence. What is the issue with the patient? Is this a clinical issue? Is it a psychological issue? Is this some like issue which has something to do with the finances, travel, situational issue? So unless you really sort that issue, that will not, it will not help to improve the adherence. So we really want like your EAC1 should actually be addressing the adherence issues. It needs to be solution oriented, right? And then it's very difficult. It's very difficult to say, because I mean, that's just the entire premise of like doing this revised guidance was that we really don't want people to be prolonging on a failing regimen. But then the other piece is we really don't want unnecessary switch. So somebody like, I mean, just take a case. If somebody is on TID, which is a very simple regimen, right? And if this person, because of some reason, cannot take one dose, one pill a day, do you think like if you really put this patient on a second line regimen, say ZL-ATVR, will this person be like adhering to that regimen, which is more complicated, and you have not addressed the adherence issues? So I think here, rather than like qualifying the time, you have to shift your gears from time to actually the quality. What quality of EAC1 and EAC2 you are doing, and that's where like medical officers should be really involved in the management of all the patients who are unsuppressed from day one. It is not just the job of the counselors that patient is unsuppressed and do a step-up counseling, but I think because like whatever messages are given or whatever solutions are provided by the medical officers or senior medical officers, they really they really work well for the patient. So please, like, I think focus on the quality and not go into the timing issue here.
If after EAC2 viral load is still more than 1000 and issue of missed dosage is still there, then what should SACP recommend even after proper counseling?
So obviously, like if there are issues of the missed dosing, there's no point like switching this patient. So obviously, please try to address the adherence issue. I think whatever I said for the previous answer, I'll have to repeat the same. So it has to be like the quality and addressing the issues of the adherence. Like, what is the issue? Is it the understanding issue or psychological issue, or logistic issue, operational issue, like no, and you can even think of like no taking help from the CSC because this number is going to be very small. You can even think of like no somebody actually going to the patient home every day and ensuring that the patient is taking drug. So you'll have to like no devise your own mechanism. But then again, when you know that the adherence is not good, there are issues of the missed dosages, there's no point in shifting the patient to a new regimen. Next one.
Even after repeat EAC, those patients with adherence less than 95, 3 months adherence with previous viral load more than 1000 copies, shall we take viral load testing as per the schedule?
Sorry, I didn't get this question. Repeat EAC question.
Repeat EAC must be second
With
EAC.
viral load more than 1000 copies.
Right.
Yeah. Yes. So EAC has to be done. So because what you are seeing here is the adherence is low. It's less than 95%. And your viral load is more than 1000 copies. So you have to repeat the EAC. I think I got the question correct. Otherwise, like when we open for the questions, we can discuss this more.
Yes, ma'am.
Next.
For HRG, do we need to check viral load every 6 months?
No, it does not depend on the type of like population. It depends on what type of regimen you are using. If the HRG is on first line regimen, then 6 months, 12 months, and then annually. If the person is on second line or third line, then every 6 months.
What will be the viral load testing schedule for children less than 5 years?
So it's the same schedule. The schedule remains the same irrespective of the age. So for first line patients, every 6 months, 12 months, and annually. And then if the child is on second line or third line, then 6 monthly.
For review of adherence, physical SASEP should be recommended at ART plus centers. The main issue is with IDUs, jail inmates, and other key populations.
So as I said, obviously, when you have these kind of populations, you have to see like how can you ensure adherence to ART or the ART retention. So especially for IDUs, try to involve the OST centers, try to involve the TI, NGOs who are working and who are in regular touch with these IDUs. Even for jail inmates, there are some good examples like where like even ART staff has gone to the prisons to dispense the drug. Even you can, for the jail inmates, you can even think of a model of a car, like if there are like 4 or 5 inmates, somebody on behalf of them can come to the ART center, because with the jails, the usual problem is the escort. So usually like there would be nobody to pick up the drugs for these jail inmates. And then these jail inmates will miss the doses. So you can think of having a car group and somebody or a jail staff can actually collect the drugs for all the patients instead of bringing the patient every time. And the same would apply for the key populations also. Please try to involve the TI NGOs for these patients. And for this physical SASEP, I think it may not be possible for all patients, especially if they are in a distant, in a different district. It won't be possible for the patients to come for the physical SASEP. But if it is your own center, then you can have a physical SASEP. But otherwise, you can do a tele-SASEP, you can do a virtual communication with the patient, telephonic call, but some sort of dialogue should be there. Obviously, whatever papers are sent by the ART center, they will not communicate enough unless you really interact with the patient and try to understand like what is the issue.
Our viral load machines detect or measure only HIV-1 cases. So how can you measure viral load quantity in HIV-2 cases?
So HIV-2 cases, I said the viral load is not to be done. So, under the national program, we are just doing the HIV-1 viral load test for if the patient has HIV-1 and 2 both, then we still do for HIV-1. But if somebody is only HIV-2, the CD4 monitoring needs to be done. Viral load test is not recommended.
What intervention can be planned for barrier of traveling or economic issue to pick up ART pills himself too?
There are like some state-specific schemes which are ongoing. You can really like discuss with your CSCs there if that's possible. And then the other thing which I said, like if you really have like barriers in terms of travel, think of like decentralizing. You use car groups, use link ART centers, use CSC, like whatever, or the TI NGOs to for the drug refills for such patients. if you don't have any scheme for travel in your states.
These are the questions from the YouTube channel. Participants who are viewing this session there. If a patient just completed his ATT drugs and his viral load is not done even once, then when should viral load testing be done?
So ATT drugs are not a contraindication for doing the viral load testing. Viral load test should be done as per schedule. And in case if it has not been done, you do it after like no ATT. I mean, whenever the patient is coming, you can do the viral load test.
Can EAC be done on video call if some problem arises suddenly in a month?
Yes, definitely. If you think like no, your patient is like no really like no, you think like no, you need a more regular follow up. Like no, maybe like 1 month follow up is not enough. You think like no, you need to follow up these patients like no more regularly. Tell them that you will be making a video call and just discuss with them like no on a weekly basis. Remind them. So you can always use these kind of modalities to make your EAC effective. Because at times, like no, for some patients, 1 month period is too much of a period that they will not remember the messages you gave. So doing a video call could be a good way of like no, doing a more frequent touch with your patient.
If a patient is detected HIV during ANC during 20 weeks of pregnancy, is she eligible for viral load testing immediately during registration in ART?
So detected during 20 weeks of pregnancy, obviously you will start ART here. And when this woman actually reaches 32 weeks of pregnancy, then you do a viral load test.
These are the questions from the chat box and YouTube channel, ma'am. We'll take up the questions from the remaining questions from the chat box. We are opening up the mic access now. Kiran sir, we can give mic access to everyone. Praveen sir.
Given, ma'am.
Thank you. Mic access has been given to all the participants. In case they have any questions, you can unmute and ask questions. We are taking the questions from chat box separately.
Ma'am, hello.
Yes, yes, sir.
Yes, please go ahead.
I am SMO from ART Center, Bhubaneswar.
Yeah.
My question is this U is equal to U applicable to mother to child transmission?
Yes, I mean, the language which is used is there's very minimal risk because you see when we talk about the vertical transmission, it can happen like no during pregnancy, during delivery, and during breastfeeding period. So and ensuring that adherence of the women, because you did a one-time viral load test, right? So you do not know whether like no, suppose you did a viral load test at 32 weeks. And at that time, the mother was like no suppressed, but you do not know what will happen during the breastfeeding. She may not take treatment. She may not be on treatment at that time. So that's why like no, even if you do like no say 32 weeks and if she delivers like no say 38 weeks and maybe during the last month she was not taking ART. So there is always this slight risk with the pregnant women, and a continuity of the viral load suppression is or having a non-detectable viral load throughout the pregnancy, during delivery, and during breastfeeding is a must. And that's why like no, to be on safer side, the language which we use is like no, there is a very minimal risk if the pregnant woman is suppressed. But the message of U equal to U, like no, I mean, as a principle, it is applicable.
Madam, my point of view is if everything is okay and the patient is adherent, then only.
Yes. So that's what I'm saying. In principle, it is, but then still like no, you don't know like no all these slight chances.
Okay.
Because so maybe like no, you put somebody on ART like no say during like no second trimester, and after that she's like no suppressed. But then something might have happened in first trimester as well. So I mean there is very minimal thing kind of risk kind of a thing, and that's why I think in the WHO guideline. There is this very cautious use of word like there is a very minimal risk.
Participants can unmute their mic and ask questions.
Hello.
Yes, ma'am.
Hello, ma'am. This is Dr. Shilpa from Sagar ART. Ma'am,
Yes,
for NFU trackback patient, if the baseline viral load is not done because of the adherence because the patient is always in miss of 1 or 2 or LFU. Can we take the baseline viral load on his visit?
Can you repeat your question, please?
Ma'am, for LFU trackback patient whose baseline viral load is not done because of his adherence issue, he is never adherence, his adherence is never proper. So can we take the baseline viral load on his visit even after he is LFU or miss?
No. Because obviously the patient was missed or LFU and he was off ART. So at least you want to expose this patient with 3 months of ART with EAC. That means that he should be like adherent to ART. You are doing a good EAC and the patient is taking 3 months of ART, then only you do a viral load test. Baseline viral load test in this condition will not give you any sort of...
But even then, ma'am, these patients are not coming on time. Even after EAC, they are not coming on time.
See, ma'am, we already had this very elaborated discussion on the quality of EAC. So now, this number of patients who are unsuppressed or who are LFU, this number is not a very big number, and that's where ART centers need to focus more on these priority groups.
Okay.
And what best can be done. I know there are when we talk in the practical scenarios, there are real issues, but then these needs to be dealt case by case. I cannot give you a prescription here what to do, but then you need to, I mean, that the bottom line is please identify the barrier. Unless you address the barrier, your patient is not going to be adhered or retained. So that is the bottom line, I'll say.
Hello, good afternoon, ma'am. Dr. Neetu from KGMC.
Good afternoon, Dr. Neetu.
Ma'am, my question is, even after EAC2, viral load is greater than 1000 and adherence issue is still there in some cases. So when the next viral load be done, will that be done routinely or will that depend upon the adherence?
No, so I think, sorry, I missed saying something in this these slides, and in the guidance document, it is very much there. So the viral load can be done at the clinical discretion, whenever the SMO, MO, or SSF feels additional viral load can be done. So whenever you are asking as a SSF, whenever you are recommending, you can always say that please do a viral load after 3 months or maybe 2 months.
Now, suppose
So
patient
those
doses, if the patient keeps on missing the doses every month, so we can postpone the viral load till the adherence is good?
No, I think because I think what as a TRG we took call that we just postpone the viral load for 6 months. So after 6 months, if the patient is still non-adherent, we do a viral load. Right? And then send the patient to the SASF.
Even after 6
now,
months.
SASF feels that it's still non-adherent. I think because you are again so EAC1 is your first level of intensified counseling. Then there is next set. EAC2 is just a step further. Okay. You further
I'm asking about even after EAC2, viral load is increased.
I'm coming to that. I'm coming to that now, Dr. Neetu. So EAC2 is it's expected that, okay, whatever you missed in EAC1, that should be addressed in EAC2, right? So it is like a second level of intensification. And when the patient is coming to SASF, still non-adherent, and SASF is actually sending back that, okay, you continue with the EAC. So in this, obviously, you really want to be very, you want to measure the impact of your EAC. So you don't want to postpone the viral load testing. Do the viral load testing in 3 months in such patients and see what is happening.
Okay, ma'am.
Because at times, even having a viral load result will help to counsel the patient better. Okay, last time, and at times what happens, there is a log decrease in the viral loads. Okay. So you can always say, okay, last time your adherence was say 70%, but now your adherence was 85%, and your viral load has actually come down. So you please maintain that pace and be more adherent to the ART, and you will be suppressed.
So from after EAC2, if viral load is greater than 1000, we'll repeat a viral load after 3 months. You're saying, na? After 3 months, we'll repeat again. Even if adherence is not.
Yes.
Even if adherence is not. Okay.
Yes.
Thank you.
Kiran sir, if you can please.
Good afternoon, ma'am. I am Sohini Jain. from
Yes.
lab technician from ART LVSH. My question is that if after EAC1 patient is having good adherence, let's say now more than 95% during EAC1, and patient viral load is decreased as it was initially, but not less than 1,000. Suppose it was 5 lakh initially and it came to 50,000 after EAC1, but it is still more than 1,000. So what should we do after this? Should we refer it to SESAB or should we start it on EAC2?
So is the patient adherent or not adherent?
Yes, ma'am. Patient is adherent and
Patient is
viral load is decreased a lot.
So patient is adherent. Obviously, I mean, as per guidelines, this patient has to be referred to SESAB, but then in this case, SESAB will again take a decision that you start a EAC2.
Okay. So we should finally started it on EAC2.
Yes. Ultimately, this patient would be started on EAC2.
Okay. Thank you so much, ma'am.
Ma'am, this is in continuation with the earlier question about
Yes.
ANC. It is written for positive pregnant women already on ART. Should we not do a viral load when they first report their pregnancy at the ART center? This way, we can pick poor adherence much earlier, and ART or SASIP has plenty of time for EAC and interventions.
So somebody who is not on ART, what will what viral load at the first date say? Like whenever you initiate, so that will not help actually. So basically, if you are starting somebody very early in the pregnancy, obviously you're 32. You can even think of doing a viral load after 6 months as per the schedule, the routine schedule. But then at 32 weeks, you need to still do an additional viral load to understand that whether the women is still suppressed or not, and what sort of prophylaxis do you need to give to the baby. So I think these are two separate issues. 32 weeks is, we don't want to prepone that, because 32 to 36 weeks was said because usually that's the time when a women will deliver, 36 weeks, 37 weeks, 38 weeks. So we really want to have a viral load report before the women delivers. And that's why 32 to 36 weeks is being recommended. But then the scheduled viral load, which is to be done at 6 months, that can be continued. But not after the first pickup. I mean, obviously, you do not know. I mean, after first pickup, you don't expect a viral load suppression. So, there's no such guidance, but you monitor the adherence of the women. There are other methods, you see into the pill pickup date, you see into the pill count. So those are the things which need to be used for such patients.
Next question has been taken up. The next question: if any patient is bedridden and lab technician is ready for home visit, can lab technician visit home to collect blood sample with CSC personnel?
So I think this guidance would have to come from your state. From NACO's side, there's no such guidance. But if your state is having such kind of initiatives, I know some states are doing it. So if your state, if your SACS is in agreement, this can be done. But from my side, I am not prescribing anything here. But a decentralized viral load collection at even at a LAC for such patients can be considered, but then please seek permission from your SACS, because there are some procedures which need to be followed during sample collection, and some environmental conditions. So those needs to be ensured. So if your SACS is agreeing and giving you approval, it is fine, but not without the SACS approval.
Mic access will be given to participants in another 5 minutes, requesting them to please place their questions in the chat box till then. Ma'am, the next question has been taken, right?
Yes.
Too high or viral load.
Yes.
What about proxy cases and adherence? How can adherence be monitored?
So for your proxy cases, for how long they can be proxy, that is one. And secondly, for the proxy cases, please try to use the mechanism of CARG models. I think this model was actually devised for that very purpose. And please go back into the ART operational guidelines, and you can formalize the proxy cases into CARG, and at least these proxy cases should be ideally they should be visiting your ART center in 3 months. If not in 3 months, at least I know there are some hilly terrains, and I here I'm not please don't generalize me. Don't no, this should not be used as a guidance. But I know there are difficult terrains where it is very difficult to for the patients to come in. So that's where at least your patient should be coming to the ART centers at least once in 6 months.
Ma'am, I'm not sure about this question. Calculation of viral load, eligibility of PLHIV for reporting.
So all PLHIV who have completed at least 6 months on ART, all are eligible as per their frequency.
Right.
But the only eligibility criteria is 6 months on ART is a must.
Right. Viral load is TNT, but CD4 is declining. It declined from 180 to 40 in 180 months. Angioplasty has been done and patient is on aspirin, rosuvastatin and clopidogrel. Again, question is not very clear. Shall I go to the next question?
You should make such referrals to your COE, and if for such cases, maybe you need to even look into HIV-2 infection here. It could be a case of co-infection of HIV-1 and 2 as well. So, and there are other clinical aspects which need to be looked into. So please, whenever you have these kind of cases, please do take opinion from your COEs.
The next question has been taken.
COEs.
For patients on second line, does adherence of last 3 months should be more than 95% on second line ART?
So I think the scheduled viral load needs to be done as per schedule. Whether the patient is on first line, second line, or third line doesn't matter. If a patient is due for a viral load test, that test should be done irrespective of the adherence.
Is U is equal to U applicable for MSM patients as well?
U equal to U is applicable for sexual transmission. So it would be applicable for MSMs as well. But as of now, it is not applicable for the injecting drug users.
For a positive pregnant woman already on ART, should we not do a viral load when they, sorry ma'am.
Yeah, this was discussed, yeah.
Okay, we have few questions in the chat box again, ma'am. Okay. If U is equal to U, patients can have unprotected sexual contact with spouse who is negative. Can a person with undetected viral load have unprotected sex with his spouse?
So basically, as per the U equal to U messaging, the risk of sexual transmission is 0, but then the risk of transmission of other STIs is still there, and we do recommend a condom use. Because I think the program under which we work is HIV as well as STI control program.
When do we do viral load for PLHIV who has switched regimen?
Yes, somebody who switched would be either on second line or a third line. So you need to do a viral load after 6 months.
Ma'am, there's been a request to repeat the answer since they had connectivity issue. When to do viral load testing after ATT completion?
So the viral load timing does not depend on the timings of ATT or completion of ATT. Viral load should be done as per schedule.
Can a patient with TB undergo routine viral load testing? What should be the viral load? What should be done if the viral load is more than 1,000?
Yes, such patients can go a routine viral load testing. And obviously, if the viral load is more than 1,000, it could be because of the clinical condition. It could be because of the adherence issue. You need to do a EAC and look into the adherence issues.
If a patient referred to SACEP after 2 unsuppressed viral load, next viral load, when to do if SACEP reply? So if there's a delay in SACEP reply, like for 3 months, there's no reply, what should be done?
I think this should be discussed with SACs, that there should not be such delays of 3 months. So please reach out to your SACs.
Is there any correlation of viral load and clinical symptoms?
Is there a correlation of clinical viral load and
clinical symptoms?
It could be if somebody like, if you're ideally like, the purpose of doing the viral load test is that you really want to identify the failure earlier before the clinical symptoms set in. But if the viral load has not been done for quite a long time, or maybe for the adherence issues, you're not doing it, and patient might be really like, may not be responding to ART. So he might have like clinical symptoms there. So there might be an onset of clinical failure as well.
Ma'am,
And that's why like doing your timely viral load is very critical.
When will we do viral load testing in alternate second line?
Does not matter whether it's the alternate or the normal second line, every 6 months it has to be done.
Does U is equal to U mean 100% untransmittable?
Sorry, Shweta, if you switch or if you transition any patient from any regimen, like whether it is a substitution or switch, it's ideally good to do a viral load test at 6 months in such patients.
Is U is equal to U 100% untransmittable?
For sexual transmission. But this is a very dynamic condition. U equal to U means that somebody who is like having an undetectable viral load should sustain this to an undetectable level. So that there is like this thing that whenever you're like communicating to your patient that this status has to be maintained, patient needs to be adherent and have an undetectable viral load. Because if tomorrow says if a viral load was done like 2 months back and today's patient is not taking ART, then U equal to U doesn't work. So adherence to ART is the key along with U equal to U.
Yeah, continuing with the U is equal to U thing, can discordant couples plan for pregnancy without any risk if U is equal to U?
Yes, so there's discussion in the EVTHS guideline, and I mean, and you will receive guidance about this very soon.
Thank you, ma'am. We have overshot the time. Thank you for being with us. Ma'am, can we continue taking questions?
No, I think I have a hard stop, but if there are questions, please ask them to like write in the chat box and I respond later on.
I missed that. Yes. Thank you to all the participants. Please keep adding your questions in the chat box. We'll remain here till 3 p.m. Ma'am, thank you so much for facilitating this session. It was a very important session. Thank you to Purnima ma'am as well. Thank you to Dr. Bhawani sir in absentia. Dr. Purnima ma'am, would you like to give some closing remarks?
Thank you, Shweta, and thank you, Dr. Reshu, for such a wonderful session. And I'm so happy to see it was so interactive and people were asking questions. I just wanted to reiterate 3 things which Dr. Reshu very simply and clearly mentioned in her presentation is the importance of EAC when we are looking at patients who are unsuppressed, importance of involvement of MO when we see an unsuppressed who is not adherent to ART. The involvement of a medical officer at the ART center is extremely important. And third point is that when we are recommending for a SASAP referral, we do a complete analysis before we are referring to the SASAP and ensure that there's no unnecessary switches or substitutions, analyze the situation, the clinical condition of the patient or any other barriers to adherence so that we are taking the right call for the patient. So these are 3 things which I would like to request all the medical officers and counselors of the ART centers to ensure when a non-adherent patient reports at the ART center based on the guidance which is given in the NACO's OM. So that's all from my side. Thank you, Shweta, and thank you, Dr. Reshu.
Thank you so much, ma'am.
Thank you so much, everyone. Thank you, Dr. Purnima, and thanks to all the participants and the ITech team. Thank you so much.
Thank you, ma'am.
I'll try to answer these questions, so just give me the list of the
I'll do that, ma'am.
Thank you.
Kalyani ma'am, requesting you to please put your question in the chat box. For participants, we'll keep this session open till 3 o'clock. Please keep posting your questions in the chat box. I have skipped few questions which were answered, so you will get those answers in the recording. We'll send the recorded link along with the PPT to all the participants, as well the ART centers and the SACs also.
Shweta, one more thing. I think there was a request for the IPT session that will be planned soon, just for the information of the participants.
Right, ma'am. Thank you. Thank you, Purnima ma'am. For the participants, thank you so much. Yeah, thank you, ma'am. Thank you so much for your active participation and being with us today, even at 1 o'clock. You can keep posting your questions in the chat box. We are here. We are keeping the session open till 3 o'clock. Please feel free to post your questions in the chat box. You can also write to us at dlcsinfo@itechindia.org. Kiran, can you please give mic access to Kalyani ma'am and Surinder Singh sir? Sure. Kalyani ma'am, can you please unmute? You have raised your hand. Surinder sir, would you like to ask any question or any comment? Participants can put their questions in the chat box. We are keeping the meeting open till 3 o'clock. Okay, Surinder sir. Mic access can be taken away. If there are any questions, participants can put their questions in the chat box. We'll send the answers through email later. Recording has been stopped, but you can place your questions in the chat box. We'll be here for another 10 minutes.